Today we're diving into one of the body's most powerful yet often overlooked regulators of human function, the pituitary gland, sometimes called the master gland. When disorders of the pituitary go undetected, they can disrupt the entire body's function, leading to complex and sometimes life-altering conditions.
Welcome to Baptist Health Doc to Doc, a podcast built for innovation and collaboration by physicians for physicians.
Hello, I'm Dr. Michael McDermott, the Chief Medical Executive and Irma and Kalman Bass Endowed Chair in Clinical Neuroscience at Baptist Health, Miami Neuroscience Institute. Joining us today is Dr. Evan Bander, Director of Endoscopic Skull-Base Surgery and Co-Director of the Pituitary Program and a neurosurgeon at Baptist Health, Miami Neuroscience Institute. Evan?
Thank you for having me.
Could you please tell us to start about your training and specifically endoscopic surgery for pituitary tumors?
Yeah, of course. So, I grew up in New York, and most of my training was done in New York City. I trained at Weill Cornell, New York Presbyterian, for neurosurgery residency. And while I was there, I was trained by one of the leading endoscopic neurosurgeons, Dr. Theodore Schwartz, who really pioneered the use of endoscopic endonasal surgery for pituitary tumors. So as a neurosurgery resident, I decided to do a subspecialty focus in pituitary tumors and paracellular tumors, and really all of minimally invasive neurosurgery with Dr. Schwartz at Cornell. In addition to that, I actually did an additional fellowship in neurosurgical oncology at MD Anderson Cancer Center in Houston, Texas, where I also learned additional advanced endoscopic techniques with really pioneers in the field of treating other tumors around the pituitary gland, including chordomas and skull-base tumors.
Great. What about pituitary disorders interested you as a neurosurgeon to focus your practice in this area?
Well, really, my interest came from an interest in really all brain tumors and being able to sort of treat and support patients through these really difficult diagnoses. As a neurosurgeon, it's our job and our ability to take the opportunity to support these patients and their families after getting this very difficult diagnosis and get the patient to a more functional, or at least help them maintain their quality of life after such a diagnosis. And when it came to pituitary tumors, really these are the second most common tumor we see in the benign brain tumor field, right after meningiomas, which you know plenty about. And pituitary adenomas can have really important impact on patients' function. Mm-hmm. A pituitary tumor can affect a patient's vision, which obviously can severely impact their ability to function normally, as well as functional pituitary adenomas can really have a strong impact on a wide range of systemic functions throughout our body, metabolism, growth, et cetera. So pituitary tumors really require subspecialty focus. These patients, in neurosurgery, we have a certain skill set, but pituitary tumors really require a specific set of skills to treat these endoscopically, which is different than our typical open procedures.
Mm-hmm. Now, for our medical colleagues who are watching, can you discuss the most common syndromes for functional pituitary tumors, and what are they commonly called?
So functional pituitary tumors can come in a few different forms. One of the most common, and actually the most common, is prolactinomas, so tumors of the pituitary gland that secrete excess prolactin. And prolactin can have multiple effects on the body, including causing what we call galactorrhea, or excessive production of milk from the breasts. There can also be effects on sexual function, sexual dysfunction, as well as osteoporosis. In women in particular, you can have irregular menses, and that's how many of these patients can present. That's the most common functional pituitary tumor, but one of the more widespread effects of the pituitary gland is really from cortisol. And so one functional adenoma is a ACTH secreting adenoma, which causes Cushing's disease, which can have significant effect on the body, including effects on metabolism, weight gain. Patients can have osteoporosis, weakening of their bones, frequent fracturing of their bones. They can have significant effects on diabetes, high blood pressure, really affects multiple organs throughout our body, which can extremely be difficult for patients and also be difficult to diagnose because of the widespread effects. And so that really takes a specialized diagnostician to help diagnose these patients. Other than ACTH secreting tumors or Cushing's disease, the other more common functional adenoma is acromegaly or gigantism in kids, which is a pituitary tumor that is secreting growth hormone. And so that can cause excessive growth of the hands and feet. Patients may notice that they're increasing shoe size or increasing hand size, glove size. They may notice different facial features, including widening of the nose and frontal bossing. So these features can sometimes present with acromegaly.
Is it true that these two functional tumors, ACTH producing and growth hormone secreting tumors, can shorten a patient's life and if undiagnosed and treated properly?
Yes, absolutely. Particularly Cushing's disease and acromegaly of the functional adenomas, they can definitely severely affect a patient's overall lifespan.
What about non-functional tumors? How do they present?
So non-functional pituitary tumors can actually go unnoticed for a very long period of time. Many patients present incidentally in an emergency room after a car accident, getting a CT scan. They get noticed to have a non-functional adenoma. Some patients present with headaches or sort of vague symptoms. But really the most common finding that we see from large non-functional adenomas is vision loss. So patients can present with severe vision loss, particularly bitemporal hemianopsia or loss of vision in the periphery from compression of the optic chiasm from these tumors.
Do all non-functional tumors that are not symptomatic require surgical treatment?
So non-functional adenomas, it really takes a lot of workup and thought in terms of how to treat these. Observation is very reasonable for non-functional adenomas that are not compressing the optic chiasm. For tumors that are growing or for tumors that have compression of the optic chiasm on imaging or evidence of visual loss, even subclinical vision loss, that could be an indication for surgery.
So a non-functional adenoma that's touching the underside of the chiasm with normal Humphrey visual fields and oculocoherence tomography testing and acuity, does that require surgical treatment?
So really that depends on a patient and their age, how they, what their field of work is, what their expectations of, their long-term outcomes will be. So it's a discussion with a patient. I don't tell anyone you need surgery unless, it's something that they're willing to undergo and understand the risks and the benefits of it. But certainly in a younger patient who has a tumor that's touching the optic chiasm, to prevent vision loss or to prevent worsening of their vision, surgery can be indicated, even if they have no evidence of vision loss yet.
So let's say you've decided with the patient that surgery is necessary. What kind of preoperative workup do you routinely do before surgery?
That's sort of the beauty of a pituitary center is that the workup is really a very important part of the decision-making process for a pituitary tumor. So that workup generally includes blood testing. So we test all of the hormones that the pituitary normally produces, and we do that in conjunction with our endocrinologist as part of our pituitary center. We look at all of these hormones and assess, is this a functional adenoma or a non-functional adenoma? That's really the first step in determining treatment paradigms for these tumors. And once we can determine whether this is a functional or a non-functional tumor, then we can start looking at the anatomy, looking at our MRI scans, our CT scans, assessing whether there's this tumor is touching the optic chiasm, whether there's room between the optic chiasm and the tumor itself. And that sort of anatomical decision-making can play into whether this is a functional or non-functional adenoma. We talked about prolactinomas. So a very large prolactinoma can be touching the optic chiasm, but if we have endocrinologic evidence that this is secreting prolactin, even if they have visual deficits, it may be reasonable to start with medication. Prolactinomas are one of the few pituitary tumors that are actually quite responsive to medication. So those kinds of conversations are really important in a pituitary center in a multidisciplinary manner.
During surgery, what kind of specialty equipment and colleagues do you use to carry out these operations?
So, for pituitary tumor surgery, endoscopic endonasal surgery has really come to the forefront of treatment. In the past, neurosurgeons often would do craniotomies for treating these tumors or do transsphenoidal surgery through a microscope, but really an endoscope is a long telescope that brings the illumination and the camera to the depth of the field inside the nose. And so that really allows for a wider field of view within the nose and within the sphenoid sinus. And so using these telescopes or endoscopes, we get a much better view of the bony anatomy. We can see the carotid arteries, which surround the pituitary gland on either side. We can visualize the cavernous sinus, and in some cases, enter the cavernous sinus if necessary. And we do this surgery with our ENT colleagues. We do this because the ENTs are experienced in opening up the sphenoid sinus and the nose and giving us access to the regions of the skull base that we need to access. And also because it improves the quality of life of these patients postoperatively. Following up with the ENT doctors can be an important part of the postoperative care of these pituitary patients.
Now, Baptist Main Hospital on North Kendall Drive has an intraoperative MR, an intraoperative CT scan. Do you use any of these after your procedure?
It's a great question. There's been a lot of studies looking at intraoperative MRI for evaluating pituitary tumors and extent of resection. And many of these studies do show that you can get a better extent of resection using intraoperative MRI. If you see residual tumor, you can go back to the surgery and complete any additional resection. So we do use our intraoperative MRI for almost all of our pituitary patients here at Miami Neuroscience Institute.
Now, you've mentioned I've been in neurosurgery since 1988, so I've lived through the microscopic, transnasal, sublabial times. Now we're using the endoscope exclusively. The cavernous sinus was usually considered no man's land in the past, but not so much anymore. And is there anything that you use on preoperative imaging to determine whether or not there's cavernous sinus invasion, and does that alter what you do intraoperatively?
Absolutely. So, our MRIs are very helpful for preoperative imaging in terms of evaluating for cavernous sinus invasion. And whether to open the cavernous sinus is a question that is also determined by patient factors, whether they have a non-functional adenoma versus a functional adenoma, whether this is their first surgery or redo surgery. So not everybody who has cavernous sinus invasion requires opening the cavernous sinus on the first surgery, but it's something that we're now capable of doing because we have this experience and because we have endoscopes that can help us visualize the carotid artery, which sits within the cavernous sinus, better than the microscope used to be able to. We can see everything and allow for more microscopic dissection as we're used to in sort of open cranial neurosurgery. We can now use more two-handed dissection and opening of the cavernous sinus in a more safe manner with low rates of injury to the carotid arteries.
Yeah, one thing I want to bring up for our viewers is intraoperative carotid artery injury,
right?
Which is obviously potentially life-threatening, could be morbid. But with the endoscopic techniques, we've developed methods at least to temporize to get hemostasis and then follow that up with angiography and determine whether the patient needs other treatment. Do you want to tell our viewers what the standard methods are for dealing with intraoperative carotid artery injury?
In most cases, we hope to never have that experience, to have an intraoperative carotid injury. It is reported rarely in the literature, and in many cases, you have to be very careful working around the carotid artery to avoid this. And that's why specialized training in endoscopic endonasal surgery is recommended for anyone who's going to do such an opening. That being said, when you do have these rare events, obtaining hemostasis, visualizing, because you can visualize exactly where you may have had that injury, you can see, did you avulse a small vessel? You can apply pressure like in any hemostasis, in any attempted hemostasis, you apply pressure directly to the region, and then you obtain hemostasis to get the patient to an endovascular procedure.
Yeah, can you talk about the use of the patient's own muscle tissue as a patch temporarily, as advocated by the Australian group?
I mean, there are a lot of different ways that you can obtain hemostasis, and using a muscle patch, using things like Tisiel or other hemostatic agents, Flow-Seal, these are all options. In most cases, you're really just trying to obtain the basic hemostasis so that you can protect a patient from losing excessive amounts of blood.
Yeah. I've had one intraoperative experience with a carotid rupture. It was unpleasant. It wasn't my case, but I was called to help. And as you said, once we got the bleeding controlled with direct pressure, we were able to take the patient to angiography, then underwent endovascular repair. Ultimately, the patient did fine, and on a delayed basis went back for the definitive surgery. Kudos to them for the courage to go back after an event like that. But you really don't want to have that intraoperative experience as a neurosurgeon or a rhinologist.
Yeah, that's going to be very scary.
So once the surgery is done, how long do the patients stay in hospital, and are there any other specialists that you get to see the patients before they go home?
So, most patients stay in the hospital around 2 to 3 days at minimum after a surgery like this, mostly because after pituitary surgery, we're monitoring patients' electrolytes. Patients can experience things like diabetes insipidus after resection of a pituitary tumor, as well as delayed hyponatremia. So these are things that we try to monitor for in the first 48 to 72 hours after surgery, monitoring the sodium balance, and if we see signs of diabetes insipidus, treating it appropriately in the hospital. So most patients, it's about 2 to 3 days after surgery. That being said, some patients can have a longer stay with intraoperative CSF leak or cerebrospinal fluid leak. We do sometimes place lumbar drains, which we may keep in for 72 hours and then get the patient out of the hospital, hopefully by day 4.
Now, the postoperative follow-up for these tumors likely is lifelong.
Right.
And how do you do that follow-up? And are there any options for patients who've already had surgery when their tumor recurs?
So, as you were mentioning, because these are benign tumors, they can slowly recur over a patient's lifetime. But in general, patients have very good long-term outcomes and good control after a gross total resection of a pituitary tumor. So in patients who do have a recurrence, those are things that we look at. Is surgery another option? If this is a tumor that is in an accessible area, we do often do a second surgery for recurrence. In patients who are older or may be less amenable to a surgery for medical risk factors or medical comorbidities, radiation or stereotactic radiosurgery with our radiation oncology colleagues is also an option. And medications in patients with functional pituitary adenomas is sometimes also an option that we always consider.
Yeah. And what types of radiation therapy are commonly used for non-functional or functional pituitary adenomas at recurrence when repeat surgery is not an option?
So stereotactic radiosurgery is a very commonly and well-reported radiation, a form of radiation for treating pituitary adenomas, sometimes in the upfront diagnosis when patients aren't surgical candidates, but often in patients who have subtotal resections with further growth of the residual tumor, or in patients who have a recurrence and are not a surgical candidate. So gamma knife radiosurgery is something that has been reported in over thousands of patients with excellent outcomes, and control rates up to 90% in some cases at 5 to 10 years. So it is definitely a good option. For patients even with functional pituitary tumors, we do sometimes treat these with stereotactic radiosurgery. And it's something that we discuss with every patient. We talk about all of the options up front. And stereotactic radiosurgery has been shown to be effective in some cases of Cushing's disease and ACTH secreting adenomas and acromegaly. Although one of the downsides of that is that you can have delayed response times for endocrine function. So both the response in decreasing the excess production of ACTH or growth hormone, that can happen in a delayed fashion as opposed to surgery, which can be almost immediate. And secondly, patients after stereotactic radiosurgery can have higher rates of hypopituitarism or panhypopituitarism after radiation.
Yeah, thanks for pointing out the distinction between radiographic control versus endocrine control.
Right.
The radiographic control is more obvious early on, and the endocrine control takes later. Any difference between the follow-up between a functional adenoma and a non-functional adenoma?
Well, so a non-functional adenoma in a patient who gets a gross total resection and doesn't have any postoperative hormone deficits may just need to follow with a neurosurgeon. We follow them over time because, again, this can have a slow rate of recurrence. We do follow patients, at first every 6 months, and then in a year, and then every year, and then eventually we spread out that follow-up. But that can often be done with just a neurosurgeon if there's no endocrinologic issues postoperatively. For patients with functional adenomas, that's often a lifelong diagnosis of following with both endocrinologists and neurosurgeons to evaluate their endocrine function postoperatively. Recurrence in Cushing's disease can occur despite resection of entire gross total resection of a tumor. Delayed recurrence can occur in Cushing's disease and often requires, very technical endocrinologic workup to diagnose that.
Great. Thank you, Dr. Bander. As we look ahead, the future of pituitary medicine is full of promise. Advancements in imaging, minimally invasive surgery, as we've just heard about, and personalized hormone therapies are opening the doors to earlier detection and more effective treatments than ever before. At Baptist Health, our commitment is not only to treat today's patients, but also to pioneer innovations that will improve care for the generations to come. Thank you for joining us on this journey. Together, we're shaping the future of brain and spine health, one breakthrough at a time.
To find out more about the topics covered on Baptist Health Doc to Doc, please visit physicianresources.baptisthealth.net.